Welcome to Health Talk. Today we are talking about atrial fibrillation, and with us we have Dr. Paul J. Wang from Stanford University, professor of medicine, part of the biodesign group by courtesy, and director of cardiac electrophysiology. So atrial fibrillation affects many people in America. Tell us, what are the statistics? Why should we care?
So atrial fibrillation is the most common heart rhythm problem in patients. It's about 3 million patients in the U.S. Overall, and it's really one of the conditions that causes a lot of symptoms, in particular that of shortness of breath, limitation of exertion, things of that nature, and its most serious consequence is that of stroke. So stroke, as you know, can be disabling, and luckily in atrial fibrillation is quite preventable. So we have really the importance of educating the general public in atrial fibrillation diagnosis really has an important role.
Now, what about, do we expect everybody by age 80 to have a high risk of atrial fibrillation? I read that somewhere.
Well, that's a really great question. So what we know is that most patients who have atrial fibrillation are ages 60 or above. And with every decade of life above 60, the rate of atrial fibrillation goes up enormously. So we know by the age of 80, you're much more likely to have atrial fibrillation than a younger individual. So that's a very important item to recognize, because we know the risk of stroke overall goes up with age. So we have an additional reason that in fact patients might have stroke, and we can prevent that. There are some patients who are younger, however, and maybe they're even 30s or younger, who can develop atrial fibrillation. For those patients, it's typically genetic in origin, or there may be other factors that we can discover related to their heart that might be the cause of atrial fibrillation.
Now, Evelyn, you've seen some patients with Coumadin and atrial fibrillation. You had some questions.
Yeah, we see patients a lot who come in, and a lot of them are elderly, but they're taking Coumadin, and they go through their list of drugs, and they tell me why, and it is often for an atrial fib, and I had no idea, like, why is that?
Yes. So it is a very interesting factor that, as you raise, of the role of anticoagulation in atrial fibrillation. So we do know certain patients are higher risk to have stroke in atrial fibrillation. So they're typically patients who in fact have other medical problems, such as hypertension, diabetes, heart failure. We also know that as patient gets older, they're in fact more likely to develop stroke in atrial fibrillation. So identifying atrial fibrillation in those patients is really important, because we really feel we can impact their life and their life expectancy, because we can reduce the risk of stroke with anticoagulation.
Okay. So how does someone even know that they have an atrial fibrillation? Like, do you go to the doctor, or, do you have symptoms, or what do you do?
Great, great question. So we know that some patients with atrial fibrillation, indeed many of them, don't have any symptoms at all. So they're viewed as the truly asymptomatic or minimally symptomatic patient with atrial fibrillation. Okay. Other patients may really present because they have symptoms. They may say, oh, I have a racing heart. They may develop chest pain or shortness of breath, and that might be their symptom of atrial fibrillation. It might be less specific, something like fatigue, tiredness, less energy and exertional capacity. And that might be the way in which they present with atrial fibrillation. Some patients may need emergency care even, and be brought to the emergency room because of the need to treat atrial fibrillation acutely. So the emergency department is able to do that and therefore establish the diagnosis. But for other patients, it may be a little bit of a mystery as to why they've developed these symptoms, and uncovering it with an EKG or monitoring could be very important.
Okay. So usually in a doctor's office, when they do the electrocardiogram and they figure out the rhythm is atrial fibrillation, now this is known as irregular. So tell us a little bit about that, about the rate and the rhythm, and what is it that our patients in the home audience should know about this?
Great question. So some patients may not be able to tell that their rhythm is irregular or even necessarily rapid. They aren't as aware. For other patients, they're quite acutely aware of the nature of their heart rhythm, and they can identify these irregular periods of time in their heart rhythm. Electrocardiogram, as you mentioned, is really the standard way. In fact, it's pretty simple, unlike many other medical conditions where it may be challenging to make the diagnosis. In atrial fibrillation, it's really simple. We can get an electrocardiogram, and if they're in atrial fibrillation, we can make the diagnosis. Now, there is another situation which is a little more challenging, and that is if the patient has paroxysmal atrial fibrillation, meaning that they have atrial fibrillation only from one time to one time, and it stops spontaneously. For that patient, it may be a little more difficult to establish a diagnosis because one has to do monitoring of the patient during an episode to make that diagnosis. But as I've mentioned, that can be very important. We can then in fact, treat the patient, make them less symptomatic, or in fact, in some cases, reduce their risk of stroke because we've then made that diagnosis using monitoring.
So usually the symptoms that people have with atrial fibrillation are they feel something beating in their chest, they feel uncomfortable, sometimes they have shortness of breath. All these things, they go see their family doctor, and then one could expect them to then be seen by a cardiologist. So when they finally go to the cardiologist and they make the diagnosis of atrial fibrillation, what do they expect for treatment? What is the first line of therapy?
Yeah, great question. So for the patient who is symptomatic, once we've addressed their risk of anticoagulation, we would then ask the question, is their rate relatively fast or is it of a reasonably controlled rate? So as just a rough indicator, one's typical heart rate in normal rhythm is roughly 50 to 80 beats per minute at rest. So for the patient in atrial fibrillation, for example, they might have a much higher rate at rest. It might be 90 to 120 or more at rest. So for those patients, the very first principle really is to establish better rate control. So how do we do that? Well, it's pretty simple. So when I describe this treatment plan to patients, I say, well, the heart is like a two-story house. And so there's a top floor and a bottom floor. And there's a staircase connecting the top and bottom floors. So what we do is we concentrate on how many impulses get from the top to the bottom using the staircase. So medications that affect how many beats they get from top to the bottom are ones that are most useful in controlling the rate, because it's how many impulses that get to the bottom floor that determine what their heart rate is, their pulse, etc. So simply using medications that can do that would be our first strategy.
So here's the heart, and then we have the upper floor and the bottom floor. And so tell us a little bit about what controls
Sure. So the conduction from the top to the bottom, as I mentioned, goes through this specialized staircase, and that's called the AV node. So the AV node is very susceptible to changes based on one's exertional status and, in fact, what we say is the autonomic nervous system.
Show us the AV node.
So the AV node would be located in the mid portion between the upper and lower chambers. So right really in between that. And so when we consider that, we know that we can affect the heart rate simply by using medications that, in fact, can control the amount of impulses that get through. So in doing so, we then are typically able to reduce the heart rate even with exertion, because the patient with atrial fibrillation typically has an exaggerated response to exertion. So we might walk down the hall and our heart rate might go from 60 to 80. The patient with atrial fibrillation might go from 70 to 150, just walking down the hall. So by controlling the AV node better, we can therefore have a better situation where the patient is able to do more, in fact, is more tolerant of their condition. So once we establish rate control, as we say, control of the number of impulses that get from the top to the bottom, we can then look at whether we can adequately restore the rhythm back to normal. So we call that rhythm control. So the ability to control the rhythm, that is, convert it back to normal and maintain normal rhythm, becomes really our next step in our tiered therapy of how we approach atrial fibrillation. The majority of patients will receive some form of rhythm control because we've decided that even after we've gotten rate control, they in fact are symptomatic still. And using the principle of trying to really make them feel as well as we can, that is, minimize any symptoms, that really leads us to using rhythm control. So how do we approach rhythm control? So typically we approach rhythm control by using certain medications, and we call those antiarrhythmic drugs. So as the name indicates, these are medications directed specifically to the heart rhythm problem, in this case atrial fibrillation. So in doing so, we can find very effectively that many patients can respond to these medications and therefore reestablish sinus or normal rhythm, as we would say.
So Kimberly does a lot of translation among the Vietnamese population, our community here in San Jose, which is very large. I'm sure you've seen patients who've asked you about stroke, and what do you think are the questions that you could help them? Now that we have Dr. Wang here, we can ask him questions.
Yeah, so I think most patients would want to know, like, what are some ways to help reduce the risk of stroke? Like, after getting it once, like, are they more likely to get it again? Like, how can they reduce the risk of it?
Yeah, excellent question. So just as you mentioned, having a prior stroke is a major risk factor for, in fact, having another episode. So we're really, in the investigation of a patient who presents with a stroke, it's really important to know, do we feel it, in fact, is due to atrial fibrillation? As I mentioned, we really believe we can reduce that risk to a very small risk by using adequate anticoagulation. One of the new features of anticoagulation is that now there are a number of agents that can be used. We have warfarin, also called Coumadin, which has been around for many decades, but now we have a number of novel agents, the novel anticoagulants, that can be used as alternatives. They have the potential advantage of really not having the same degree of drug or food interactions as warfarin, and they do not require the routine blood testing that it's involved using warfarin or Coumadin. So there is some attraction in using these agents as well. So there are a variety of different choices that we now have that can be used to minimize the risk of stroke.
Before they used warfarin or Coumadin, and one had to go to the doctor's office to get blood tests of blood levels. Now they have a variety of ones where you do not have to do that so stringently.
Yes.
And what are those names that
Yes.
the patients will expect to hear?
Sure. So there's several agents now that are in fact available. They're FDA approved. There are a series of additional ones that in fact can be, that are being studied. So examples are dabigatran, rivaroxaban, or apixaban, are three of the currently available FDA-approved drugs, and we do expect a number of others. And they have small differences in terms of their tolerability, how they're delivered, how they're in fact metabolized, et cetera. So there can be various advantages. One other thing I can add, and one area we're very excited about, is there's a substantial amount of research in developing new technologies to treat and prevent a stroke that does not require anticoagulation. So that naturally has a lot of potential appeal. And these devices are intended to close off one part of the heart that's responsible for a large number of the occurrences of atrial fibrillation, and that's called the left atrial appendage. So these are actually devices that are in fact designed to plug up or fill the space of the left atrial appendage. And that is felt that potentially to reduce the risk of stroke.
Oh, show us where the left atrial appendage is.
Yes, so it's easily identifiable. So when we look at the left heart and we look at where the left ventricle is, we see the left atrium, and a large component of that is the left atrial appendage. Again, a site of significant thrombus formation, therefore an area of clot and stroke. So that is one very interesting, exciting area that we're looking forward to learning more about. We expect there to be more studies that will come out that will potentially show the degree of benefit compared to other strategies such as anticoagulation. At the beginning, many of the patients who will be most appealing for this kind of strategy will be people who cannot tolerate, for typically purposes of bleeding, the anticoagulation agents. So this will be a very exciting strategy to follow.
Now, in people with bad atrial fibrillation or atrial fibrillation not amenable to treatment, the usual treatment,
Yes.
you have other invasive procedures.
Great.
Can you tell us about them?
Oh, absolutely. I'm glad you asked that question. So, as we've mentioned, after you've achieved rate control, that is a better degree of heart rate control, and you've tried medications such as an antiarrhythmic drug to try to restore normal rhythm, one may find that still the patient remains symptomatic and therefore is looking for other solutions. For those patients, a technique we call catheter ablation is really an ideal consideration. So what does that involve? So catheters are long plastic tubes that we insert into the body. Ablation refers to killing islands of cells that are responsible for the heart rhythm problem. And so in doing so, we try to target the appropriate areas of the atrium that we think will therefore reduce in a significant reduction in atrial fibrillation. And that's where we've really been excited because the results get better and better in terms of the response to that form of treatment. So we really have a lot of optimism that that technology will lead to better and better outcomes.
In ablation, in ablating certain areas of tissues that are responsible for this bad rhythm, there are different types of delivery of energy to do that. So you want to discuss that?
Yeah, absolutely. That's a great thing to discuss because this is an area where we're innovating the greatest. So the treatment modality that's been available for the longest has used radio waves. So radio waves actually heat up the tissue in a very localized area, killing cells that are responsible for the heart rhythm problem. Now there's been available a second agent technology which is involved in freezing the tissue. So that's called cryoablation. So cryoablation is used to treat dermatologic conditions, for example, a variety of other conditions in the body. And it is now used very effectively in one of the most promising strategies in treating atrial fibrillation as well. There are studies underway. We've done some of these at Stanford, which are using other novel technologies. One includes that of use of a laser balloon catheter that is designed to deliver energy. And that's under investigation by the FDA presently as a potential new source of treatment. There are additionally other technologies that are being developed using other energy sources, ultrasound and other strategies. So we're very excited about new developments in improving technology such as involved in catheter ablation.
Now, you have the heart model right there. So once you do the catheter ablation, where is the site that you're aiming for if you show us the
Oh, that's
home
a great
audience?
question. So it turns out that when we look at the back of the heart, we see the parts of the left atrium the best. So the left atrium is in this red portion here, and you can see there are 4 different tubes that come off the left atrium. These are called the pulmonary veins, and they connect the left atrium to the lungs. That's how blood that gets oxygenated in the lungs flows back to the heart through the left atrium. So the left atrium is really the door to the rest of the heart and how the blood then returns from the lungs. And that area, for various reasons, is really the area in which we believe is most critical in the origin of atrial fibrillation. I can also point out that another technology that has been really reserved for patients that are felt to be the most advanced in terms of having atrial fibrillation. Are there technologies that can be used? And so one of the things that we've been working on developing is a combined surgical technique. So when we look at the pulmonary veins back here, what the surgeon does is through ports in the chest, little telescope holes where they use a telescope inserted into the chest and can really see these areas, these pulmonary veins. They're able to deliver energy directly onto them. And the reason we call it a hybrid procedure is, in addition to coming from the outside that I've mentioned, we then use catheters to come from the inside and finish off the areas that need to be ablated. And so that combined procedure, we think, may be an important choice and option for patients that are otherwise felt not to be suitable candidates for atrial fibrillation because it's so advanced. The atria become thickened, very enlarged, and may in fact have had atrial fibrillation for a decade or more, or a long period of time.
Oh, so for the home audience, let's go through the heart again. Maybe the cameras can zoom in onto the heart.
Sure.
So show us the heart and tell us the...
I'd be happy to. So as we look at the heart as it sits in the body, so as it would sit in my chest, we can see the different components of the heart. So we have the right side of the heart here and the left side of the heart here. And as I mentioned, there's both an upper chamber and a lower chamber on either side. So in doing so, we can see the 4 major heart chambers. And we're obviously today focusing on rhythm problems affecting the upper chambers. And atrial fibrillation, as we mentioned, is really the primary one that we looked at.
So then if you open up the heart, you'll see the upper chamber and the lower chamber.
Yes.
Maybe we can get a close-up from one of the cameras?
Sure. So when we try to look at the overall heart and we look at the upper and lower chambers, you can see that in fact, as we say, that they're chambers, literally. They're able to in fact hold the blood flow and the blood and are responsible for contraction. They're producing the blood flow to move the blood through the heart and to the rest of the body.
So now we have a close-up. So here, let me see.
So you can see on the right side, this is the inside of the right atrium. This is the inside of the left atrium and the right ventricle and the left ventricle. So we can see that they are of varying sizes, of varying degrees of complexity in terms of their internal structures, and we get a very good picture, I think, of really what the heart really looks like.
And you would call the staircase connecting the upper floor and the lower floor to be the AV node,
yes,
which is right there in the center.
So one of the interesting features of the heart in particular is that the electrical system of the heart is created by specialized heart cells. So unlike what we normally would think of as electrical conduction being carried by nerves, they're actually carried by specific heart cell types. Then, in a very unique aspect of the heart cells themselves act as electrical conduits. So unlike really almost any other part of the body, the actual heart cells do double duty. They're actually the cells that cause contraction, but they also carry the electrical signal from cell to cell. And they do that in a really remarkable way once they get the signal from the specialized conduction system, those special cells that in fact can carry the electrical signals.
So for the home audience to understand, the heart is really 2 types of system. There's a plumbing system, the pump, and the heart as a battery. So we've been talking about atrial fibrillation really as a battery, the electrical part of the heart, where we capture that on the electrocardiogram, and where we look at rate, it's like 4/4 time in music, and then the actual rhythm is the tracing the quality of this beat. So that's what we've been talking about, and the upper chamber, the lower chamber, the AV node, which is like the conductor of this, the maestro, or the staircase. So is there medicine that works just straight on the AV node and straight on the left atrium? Are there medications aimed at those 2 areas?
Yeah, great question. So the medications that we use to affect the AV node are really fairly simple medications that in fact have been available now for decades. And so they fall into 2 major categories. Beta blockers. So beta blockers actually oppose the autonomic nervous system, the part of the system that tells us to increase our heart rate with exertion, etc. So it in fact affects that and will therefore decrease the number of signals during atrial fibrillation. However, it has the additional factor that I mentioned. When one is at rest, one's heart rate may be 10 beats per minute or so lower and slower than it would otherwise be normally, because it in fact affects not only the AV node, but also the sinus node that is responsible for the heart's standard rate in normal rhythm. The agents that we talked about that are the antiarrhythmic agents that are focused on the muscle tissue itself and we use for rhythm control, restoring normal rhythm, in fact, they can have effects not only in the atrium, but also may affect the ventricles. And that is one potential limitation. And so when we look in the future of agents, antiarrhythmic drugs that will be developed, they'll actually probably be more specific for the atrium and not the entire heart, the atrium and the ventricles. And that will, I think, importantly reduce the toxicity that people have experience due to some of these medications. They're generally well tolerated, but indeed there can be some limitations. So we're very hopeful that as those medications and our knowledge of atrial fibrillation and the science will in fact give us new therapies for the future.
So to sum up for our home audience in our last 2 minutes remaining, what do you want to tell our home audience?
Great. So I would say one of the things that patients should be aware of is that in fact they might have a heart rhythm problem. That might become manifest because they notice irregularity on their own. It also might be manifest because they've had some symptoms. They might be racing of the heart, shortness of breath, chest pain, or simply feeling more fatigued and having less energy. So I would ask that consult their physician and determine, well, gee, should I get an EKG? Should I get additional monitoring? Maybe, therefore, we might be able to diagnose something like atrial fibrillation, which has an important impact on quality of life and other major conditions like stroke.
And so it's important for people to have their first EKG by age 40. And what is the subsequent recommendations for that for the American Heart Association?
Sure. Many patients do receive a routine electrocardiogram. Also, we would generally recommend that before embarking on physical exertion, etc., an exercise program, and indeed routinely at multiple visits that they would have.
So thank you for joining us. This has really been very interesting. 3 million people have this. It's very common, and it's a big risk for stroke. And if you have any questions, see your general internist, your family practitioner. And if you have other questions, you can reach Dr. Paul Wang at Stanford. And thank you for joining us at Health Talk. And if you like our program, please donate to KSAR Television, Saratoga TV. And you can watch us on YouTube. Thank you.